Thanks, Fernando and Tom. Let me just see, here we go. Those are my disclosures. So these are the list of topics that I thought would be relevant and potentially of interest to our crowd here. So we'll start off with some definitions and some statistics about types of insurance and cost sharing. Then we'll talk briefly about the Affordable Care Act, which Kim covered earlier today. We'll talk about Medicare and Medicaid, some special considerations including age 26, end of the year, and insurance and job loss, and then some non-government patient assistance, including our beloved CCFA, some letters with data, hospitals, pharma, charitable organizations, and clinical trials, and finally, my favorite, persistence. So I first want to thank a few people who helped me with this talk. You know Peter, Corey, and Jim, many of you. I wanted to point out Laura Wingate, who actually runs the education and patient advocacy and support at CCFA. She's truly spectacular. And then I also wanted to thank my nurses down in Philly, Dorothy and Michelle, who actually do all the things I'll be talking about today for me, so well, most of them. So to start with some definitions, so uninsured means no insurance of any kind. Underinsured, and this is what the first question that was on your Q&A thing, by the way, are insured all year but not enough. Or I found some more specific definitions that include medical expenses more than 10% of annual income less than 200% of the federal poverty line, and medical expenses greater than 5% of annual income, and deductibles greater than 5% of the annual income. And then cost sharing is a whole umbrella term, means payment of health care by both patient and insurance company. It's a way to pass on some of the burden to the patient. And it comes in a variety of flavors, including a deductible, which is the amount you pay before your insurance starts to pay, but you still have to pay your copay. Co-insurance, which is your share of the cost of health care services after you pay your deductible. And then copay, so that was co-insurance. Then copay is the fixed amount you pay for a health care service, which we know varies with types of service that it refers to. But the most important thing about this is that when you look at buying an insurance policy, the premium is not the most important thing you should be focusing on. It should be all these other things which end up adding up to a lot more money over the course of a year. So those often determine which plan is really best for you. So now we'll look at some numbers of Americans over 18 and over who are uninsured, starting in the first quarter of 2008. As you can see, the rates are pretty high, are now coming down thanks to the Affordable Care Act. And if we stratify by age, we see that the young folks have the high rates of uninsurance. And now the 26 to 34-year-olds are starting to dip above the 18 to 25-year-olds, partly because of the Affordable Care Act, which allows patients to stay under their family's care up until age 26 now, instead of previously where a lot of them got cut off at age 19. So some more numbers. In 2012, there were 32 million Americans under the age of 65 who were underinsured. Combined with the 47 million who were uninsured, it gives a total of a whopping 79 million. Not quite the number that McDonald's has served, but getting up there still. If you look at the states, Massachusetts had the lowest rate of uninsurance at 4%, and Texas and Nevada had the highest rates at 20%. When you combine with the underinsured, Massachusetts was still the lowest, and then these 5 states here at rates of 36 to 38%, pretty high. So why are people uninsured and underinsured? Well, for a variety of reasons. Limited income, certain demographics, Hispanics, remote rural residents, lower education levels, certain religious affiliations, unemployment, and also importantly, underemployment. The unemployment rates that are reported in the news don't include people who are underemployed, which can be 20% per year, so still very high. Not all employers provide health benefits. Sometimes the premiums, the deductibles, the co-insurances are high, the cost share burden is very high. Some plans have restricted benefits, and for the youth, some of them just feel invincible and have limited income and don't want to waste their money on health insurance that they might not need. So I'll just touch briefly sort of the condensed version of the Affordable Care Act. So enrollment for 2014 began on October 1st of last year, ended on March 31st. This year, for the coming year, enrollment started November 15th and goes until February 15th. There are special enrollment periods for certain people if you miss your deadline, which I have listed here and I won't go into due to time. Also, age 26 is on this, but we'll get to that later. So not only does the Affordable Care Act allow a lot of legal residents to get health insurance, but it actually requires them to do so. So your options are to keep your current insurance, to sign up with Obamacare, or pay a tax penalty unless you're exempt for the reasons listed here. Not only that, but employers are either required for larger businesses or incentivized for smaller businesses to help get their employees insurance. On an individual level, the Affordable Care Act expanded Medicaid to all non-Medicare eligible patients less than 65 who have low incomes. Of note, states will be 100% federally funded until 2016, at which point it goes down gradually to 90% by 2020. The Affordable Care Act created these state-based American health benefit exchanges through which people can buy coverage. They offer premium credits and cost-sharing subsidies for certain people. They got rid of the pre-existing condition exclusions, except for the grandfathered plans. And importantly also, they got rid of a lifetime limit on coverage for a lot of the benefits. So if we looked at the impact of the Affordable Care Act, it decreased the number of uninsured by 10 million in 2014. However, those may have been a lot of the people who were sort of already ready to sign up and sort of the low-hanging fruit. Patients who are going to be harder to sign up are those who have been without insurance for the longest times, or those who reside in remote areas or have lack of internet access or education or not up to date with the news. So as far as the plans, there's a catastrophic plan that's only eligible for patients under 30 who can't afford other coverage, and they must qualify for a hardship exemption as listed here, a variety of things listed here which you can look at later. The majority of the plans, so they're bronze through platinum. Bronze covers the least, platinum the highest, and therefore the premiums are the lowest for bronze, highest on platinum. However, and this is the important part, the out-of-pocket expenses are highest for the bronze, lowest for the platinum. So for our chronically ill IBD patients, they really shouldn't be getting anything lower than silver, and preferably probably a gold or platinum plan, because their out-of-pocket expenses will be really high, and it'll actually end up costing them more money in the long run. So as far as what types of insurance people have in the U.S., a lot of it's through employer or family. There's also Medicaid and Medicare, which I'll talk about, military, union, and other. So as far as to deconstruct Medicare and Medicaid a little bit for you, Medicare is a federal program run by the federal government. Medicaid is a joint federal and state program run by state government. People are eligible for Medicare if they are 65 or over, or disabled. If they have ALS, they're immediately eligible. If they have end-stage renal disease, their eligibility begins at 3 months after they get dialysis or renal transplant. And importantly for us, for IBD patients, if they're getting Social Security disability benefits for 2 years or longer, they are eligible for Medicare, which is really great. For Medicaid, eligibility is predicated upon two things: income and categorical factors listed here. Pretty much if you have very low income, a child or a pregnant woman with low income, or a lot of the disabled or older patients getting SSI assistance, you're pretty much guaranteed Medicaid. They cover inpatient and outpatient services, including drugs, and the cost depends on a variety of factors. For Medicare, the coverage is based largely on three things: federal and state laws, national coverage decisions, which are made by Medicare about what should be covered, and then local coverage decisions made by companies in each state that process claims for Medicare and then decide what's medically necessary and should be covered in that region. As far as the parts of Medicare, to deconstruct them a little bit, there's Part A, which is sort of inpatient services, hospital, nursing home, that type of facility that cover visits, tests, and procedures. There's Part B, which is largely outpatient services, but includes things like clinical research studies, ambulance, mental health, second opinion before surgery, all stuff that applies to our patients. And certain drugs, which are largely infused or injected by the doc, including infliximab and vedolizumab. Also includes enteral or total parenteral nutrition and supplies needed for that, including ostomy supplies. And also includes a few vaccines, including influenza, pneumococcus, and Hep B. Now, Medicare Part C is also called Medicare Advantage. It is Medicare, but Medicare actually pays a private insurance company like an HMO or PPO to run it for them. It includes all Part A and B coverage and often a prescription drug plan as well. It sometimes is a little cheaper. And then there's Part D, which is a drug plan. Doesn't cover all drugs. Each individual Part D plan has its own list of what the co-pays and deductibles and premiums are. It covers the injectable drugs as well as a whole variety of other like oral medications, so including like adalimumab, certolizumab, pegol, golimumab, and Zostavax. You have to pay more if you make more. And on average, for medication coverage, Part B will cover about 80%, Part D will cover about 70% pre-donut hole, and then 95% post-donut hole. So let's talk about the dreaded donut hole, which is the bane of existence for a lot of my patients, for a lot of my older patients especially. So most Medicare prescription drug plans have a coverage gap called the donut hole. This is a temporary limit on the drug coverage. It begins in 2014 when you spend $2,850 out of pocket, and it ends on January 1st on the next year, or in 2014 if you spent $4,550 out of pocket, at which point you're eligible for catastrophic coverage, which is for the rest of the year that's just a small co-pay or co-insurance. Now, things that contribute toward the donut hole to help get you out and help you get you to that $4,550 include things you pay yourself, like deductibles, copay, and co-insurance, but also some stuff that you don't pay, like a 50% manufacturer discount payment on brand name drugs. It doesn't include premiums or pharmacy dispensing fees. Once you're in the donut hole, you pay 47.5% this year. Next year will be 45% for brand name drugs and 72% for generics. Now, because Medicare doesn't always cover 100% for everybody, often people have another insurance with it, often through their spouse or an employer or a union. And there's these coordination of benefits rules which sort of determine which company, which payer will pay is a primary and secondary payer. One nice thing about Medicare is that they will pay for services rendered by the other payer so that you won't be stuck with the bill. However, it's your responsibility to make sure Medicare gets refunded, so by calling the Benefits Coordination and Recovery Center. Now, there's also something called Medigap. So for folks who don't have another insurance through their spouse or employer, they can buy a Medicare supplement insurance called Medigap, which is sold by a private company. It covers co-pays, co-insurances, and deductibles. You have to have Part A and B. You can have Part D and Medigap for drugs concurrently, but it's really in your best interest to have just Part D because the coverage is better. Also, as of January 1st, 2006, Medigap does not offer drug coverage. So now we'll talk about a few special considerations. So age 26. So with the Affordable Care Act, most plans will cover young adults under their parents' insurance up to age 26, even if they're married, living independently, or financially independent of their parents. They're in school or eligible for an employer's plan, so that's really great for them. On their birthday, on their 26th birthday, they automatically qualify for a special enrollment period. So the idea here, the important take-home message, is to get patients thinking early about age 26 to avoid missing their medications and their office visits and their tests to help avoid flares. If they don't have the option of being under their parents' plan if they're less than 26, they can always do these other options listed below. Other things to think about are at the end of the year. This is when plans tend to renew and change. Typically starts in October. So patients who consume a lot of your time with authorization and denial issues during the year, they should really probably consider a better plan. These cost more money, but in the long run, they're probably worth it because they get better coverage and they'll probably have less disease burden. Also, patients who are losing their insurance or job, they often know this ahead of time. And again, you can have advanced planning to try to avoid missing medications and having flares. So now we're going to talk about some non-patient assistance programs. So the CCFA, I think, is actually a great organization. I'm proud to be a part of it. And they have a lot of useful resources for both patients and for docs. So they have a bunch of these sort of form appeal letters that are written from the doctor to various things, to insurers, to patients, and to things like schools to help get services for your patients. This patient financial assistance program, these are letters that are written for the doctor to the patient, listing all the potential resources available to the patient to get assistance with medications, out-of-pocket expenses, ostomy supplies. What I find particularly useful are these appeal letters that go from you to the insurance company to help patients get meds and tests. An example of this is here. So this is a letter asking the insurer to pay for dose escalation for infliximab. So they say that their patient was doing well on 5 mg per kg, now is losing response, and will likely regain it with 10 mg per kg. And they cite some data here showing that a lot of patients on infliximab will lose response and then regain it once they increase their dose. Similarly, this is a letter that's written about off-label use. They first say that medication can and should be used to treat disease. Does he have a laser pointer? I don't think so. Anyway, and then they go on to say that just because something is not FDA approved doesn't mean that it's unapproved. And in fact, a lot of the medications we use for IBD. You may have one. Oh, you know what? Thanks. So a lot of the medications we use for IBD are already being used off-label. And finally, that the medication is medically necessary in this case, and therefore they should cover it. So these letters are really useful. Per the CCFA, they're underutilized. So I would strongly recommend using them because they can save you a lot of time. Other resources available through the CCFA, they have a great help center that help you find resources, answer questions. They have a variety of brochures for patients that can find out about healthcare reform, about employment issues, including FMLA, and also a bunch of webinars on the insurance marketplace and costs of IBD. In the days where we didn't have these letters, my colleagues and I would often write our own letters. And basically here I've listed a bunch of references you can use to cite a lot of really useful data if you want to do this on your own for anti-TNF dose escalation. For off-label use and dosing, I can say that I'm proud that 100% of the patients that I've wanted to put on ustekinumab for Crohn's, I've been able to. I've been also able to get them to get the Crohn's dosing 6 milligrams per kilogram for their initial dose. It has to be sub-Q because it's only available IV in a clinical trial. And I've also been able to dose escalate 100% of the patients that I've wanted to Q4 dosing, and in one case more than that, which is sort of makes it a little bit dicey. But in this case, I would cite anti-TNF data saying that biologics are often, you often need to dose escalate for loss of response. For golimumab, I've been able to successfully get it for all of my patients with Crohn's that have needed it by demonstrating prior response and then loss response to all the other anti-TNFs. If I can do it, you can do it. It just requires keeping at it and providing them with data and just jumping through the hoops, which are a large pain in the ass, but it's worth it for the patient in the long run. Other things you can cite, sometimes insurances won't pay for various tests, and here are some references you can use to support your claims that the patient needs these tests done. I want to point out we now have, in addition to the Mayo Clinic reactive, therapeutic drug monitoring for infliximab. My buddy Adam Shafitz has some proactive data, and hopefully soon he and I together will have even more proactive data when we combine our two centers. So we can use that as more ammunition to get drug levels for our patients. Don't forget about your hospital. Hospitals often can help your patients a lot for paying for things. The most helpful resource I found are social workers and financial counselors. They can help your patients get access to insurance and medications. Also, business administrators and heads of pharmacy can help set up payment plans, co-pay assistance. At times, they can even lower the price of your office visit to the Medicare rate, which tends to be lower than other plan rates. They can sometimes provide bridge funding until patients have insurance. And they even, in certain instances, can forgive some costs for a hospitalization, which is really nice. Pharma can be a resource as well. Most pharmaceutical companies have patients' assistance for underinsured, and most also have ties to charitable organizations for the uninsured to which they contribute money each year. Because infliximab and adalimumab are our most commonly used expensive medications, I'm just going to use them as an example. Infliximab, there's a program called Access One, which pretty much just checks the patient's financials. Then if they have commercial insurance, they can enroll in RemiStart, which this year patients typically will pay $50 per infusion. Next year, I've just been told, hot off the press, that there'll be a $5 copay card. This year it caps at $8,000, next year at $10,000 per the year, after which they can potentially be eligible to enroll in RemiStart Extended, where they can then have assistance getting their infliximab paid for the rest of the year. If they have Medicare, their probably best options are to use Medigap or some foundation assistance, and if they have no insurance, there's a variety of foundations that can help them. Similarly with adalimumab, if you have commercial insurance, you get help towards your deductible, $2,750 this year, $6,500 next year. After that, they have copay cards, $5 per each dose of your adalimumab, and they also give you money, $700 to $800 at most per month out-of-pocket expenses to cover. If you're more than that, you pay more than the $5. You pay the difference. It caps out at $9,000 a year. Again, if you have Medicare, you're better off getting Medigap or foundation assistance and no insurance, other assistance. So that brings us to the other assistance, these charitable foundations. The most important take-home message with this is you got to get in early in the year. The wells run dry. This is largely first come, first serve. What I found was really helpful was an organization called Needy Meds, which can connect patients to a whole variety of foundations. I've listed a few here, such as Patient Advocate Foundation, Chronic Disease Foundation, Patient Access Network Foundation, HealthWell Foundation, National Organization for Rare Disorders. A lot of these require patients to have insurance, and they'll pay, often contribute toward the co-pays, co-insurance, deductibles, sometimes the premiums, and sometimes they'll pay for things like travel and lodging to help the patient out. Don't forget about clinical trials. About a month ago, I looked on clinicaltrials.gov, and there were hundreds of actively enrolling IBD trials, including trials with old drugs, trials with new drugs and novel mechanisms of actions, nutritional therapy, fecal transplant, stem cell transplant, and other stuff like hyperbaric oxygen, even yoga, which none of us can get enough of. Since we're here at the CCFA, I feel like it's my duty to pitch our CCFA Clinical Research Alliance Study Merit UC, which is methotrexate for ulcerative colitis. Essentially, we take anybody with ulcerative colitis. They could have failed any meds and any number of meds. They get 16 weeks of open-label methotrexate and a forced steroid taper. At week 16, they get randomized to either receive placebo or methotrexate for up to 48 weeks. After 100 patients, our initial data for induction shows a 16-week corticosteroid-free response rate of 50% and remission rate of 33%, which is similar or better than the UC success data for monotherapy for infliximab or azathioprine. So it's something that's, it looks very promising. If you have anybody that you'd want to potentially enroll, just contact me or the overall PI, Hans Herfarth from University of North Carolina. And last, but finally not least, is persistence. I found in my own experience that by far the most important thing is that you just have to keep at them, keep at the insurance companies. They want to beat you down. They want to waste your time. They want to not pay for stuff. So the best way is just to keep at them, providing them with data and using your own time. They realize that the doctor's time is the weakest link, and that's what they sort of often get at. But don't give up. You can beat them. It just takes time and persistence. I found that talking to the medical director is extremely helpful. I provide them with data, tell them about your expertise in the area, even if you're not at a major medical academic center. Often many of you are leaders in IBD in your local area, have a huge referral population. You can use that to your advantage when talking to the medical director. Also remind them of the consequences of not covering your medicines, which is hospitalization and surgery, which, although very unsavory for patients, has also cost the insurance companies a lot of the money. And my advice is really just to hit them below the belt, make them squirm, put them in your shoes. Ask them, what if this were your kid or your mom or yourself? What would you do? And for some of them, I found in my experience that you have to kind of be a little bit sweet with, and some you have to sort of hit them hard. So anyway, that's it. Thanks.